lecture. And we will move to the next lecture. And the next lecture will be from Jose Name Guerra for posture with the water irrigation system. Dr. Jose?
Thank you so much for I'm going to try to share my screen. Just a second.
You must just click on the share screen button on the below. Green button, share screen.
I'm just changing the configuration of my computer because
Yes, now you are on.
Okay.
Yes, we can see. Yeah.
Okay, got it. Are you seeing my screen, the whole screen?
Yes.
Yes, so we can see whole screen.
Okay, perfect. Okay. Thank you so much. I'm Dr. Lamen, neurosurgeon from Colombia. Thank you so much to the World Federation of Neurosurgical Societies for the invitation to this webinar. I'm going to be talking about endoscopy, spine surgery, the posterior approach with water irrigation system in the next 50 minutes. So let's start. So there are two kinds of approaches to the posterior region of the spine. The uniportal approach, which uses the working channel of the scope to guide the instrument to the spine, and the bipolar approach, which use one incision for the scope and a second incision for the instruments. Both approaches are good and resolve the most problem of the spine, but I prefer personally to use the uniportal for the reason that I have been working with this method for the last 10 years. Both systems use irrigation during the entire surgery. You can use a pump, or you can let the fluid fall by gravity through the bags. The working channel of the scopes are normally 4 millimeters, and when we use a pump, we should use a pressure of the pump below the diastolic pressure of the patient in order to avoid excessive pressure to the neural structures. If you have a bleeding, you can increase the pressure of irrigation and volume, but only for a short time. Regarding the irrigation, we use normally saline irrigation or ringer. I prefer to use ringer because it's more similar to the CSF. We also, in endoscopic spine surgery, use radiofrequency because it produces less heat to the neural structure. The instruments that we use are similar to the instrument that we use in open surgery: forceps, scissors, rongeurs, and many drills like hooded, diamond, and so on. There are many brands and drills in the market. They do almost the same. One of the advantages of endoscopic spine surgery are that you perform the same skin incision to all the patients. It doesn't matter how is the weight of the patient. At the beginning of the learning curve, it is more frequently to get a complication when you start to perform endoscopic spine surgery. The rate of complication in the first 100 cases reached approximately 18 until 20%, but after the case number 100, decreased until approximately 3%. There are in the literature some publications regarding the complication related to irrigation during endoscopic spine surgery. For example, by performing a neurotomy, there are some publications that describe the increase of the pressure through the irrigation with possible effects on neurological deficit. But I have to be honest, I have been performing almost 2,000 cases in the last 10 years, and I haven't seen my patient this kind of complications. The reason could be because of the endoscopic spine system that I use, and the fact that I control the pressure and the fluid frequently during the whole surgery. I had, of course, complications like bleeding, infections, opening of the dura, but until now, No one has been a serious complication during endoscopic spine surgery. So let's move about to talking about the standard approaches. There are two access to the spine using an endoscope. The first one is the foraminal approach, and the second one is the interlaminar approach. Depending on the size of the foramen, location of the dissemination, you can select the most indicated approach. For example, the lateral, the posteroral, and extraforaminal for the foraminal approaches, and the interlaminar one. Then let me ask you the following question. Which cases are proper for endoscopic lumbar discectomy? The answer is all kinds of lumbar dissemination could be performed with the endoscopic spine surgery. For 1 to S1, interspinal, foraminal, extraforaminal, they would be appropriate to be performed with endoscopic surgery. The approach will be selected depending on the location of the problem, the height of the hip. So you can select between transforaminal or interlaminar approach. The posterolateral approach is the most common use for the transforaminal approaches, and it's most indicated when the pathology is interdiscal or when the pathology is located in the foramen. The extraforaminal approach is indicated when the pathology is in the spinal canal, the medial pathology, or mediolateral pathology located. Then let's talk about the surgical technique. Let's talk about the transforaminal approach. We start with a prone position. We try to define the entry point with the lateral X-ray. We look at the point between the facet joints and the spinal process. Then we switch the X-ray to the AP view, and we tilt the X-ray to see the parallel end plates. We mark the middle of the distal level that we want to operate. And in the cross point between the two lines, we perform a skin incision of approximately 7 millimeters. We insert a needle until we reach the middle pedicle line. Also, an X-ray lateral view to be sure that we reach the foramen. Then we remove the guide wire and we insert the dilator to the final position. We insert the working slit and that is the view that we have. We identify the anatomical structures. We prefer then the soft tissue using the probe of the radio frequency, and we cut the posterior ligament, the PLL, with a punch, and finally, with the structure, depending on the location of the, and we remove and we decompress the nerve root. Then let's move to the surgical technique of the interlaminar approach. With the development of the interlaminar approach performed by Professor Sebastian Putten in Germany, the indication of the endoscopic spine surgery increased because this new access allow us to perform over-the-top decompression, lumbar and cervical spine region that was really limited by the transforaminal approach in the past. As I told you before, we use the interlaminar window to access to the spine through the flavum ligament. This will be the view by opening of the flavum ligament. You see the dural sac and the nerve root. For the surgery, the patient in the same prone position, we mark the window in the middle of the flavum ligament, a couple millimeters away from the midline in order to avoid any conflict with the spinal process. We perform the skin incision approximately 7 millimeters, and we have to be sure that we open also the fascia of the muscles. We insert the dilator until we feel the flavum ligament, and we switch the X-ray to the lateral view, and we insert the cannula of the endoscope. We insert the endoscope, and we start to remove the muscles and soft tissues. We identify the flavum ligament and prepare the soft tissue using the radio frequency probe, and we open the inflammable ligament from the medial to the lateral aspect until we reach the medial border of the facet joint. And we have to push all the time and to perform lateral stretching of the ligament in order to see when we cut the ligament and avoid any injury of the neural structures. So we identify the neural structures and we identify the nerve root. We use the detector then to mobilize the nerve, and we use the working sleeve as a nerve retractor. You have to be careful when you rotate the sleeve because you can injure the nerve root. So after rotation, we identify the disc herniation. Okay. Finally, we open the PLL and we perform the resection of the disc as we perform normally in an open surgery. We are removing the fragments and we decompress the nerve root. So that would be a L5S1 surgery. But if we want to perform disc herniation surgeries in higher levels, or when we want to let me put a mute here of the got it. Or when we want to make spinal stenosis, then we will use a drill in order to drill the facet joint and to make the over-the-top recompression. That is needed also. This is a short video. It's an example how you can perform this severe stenosis uses endoscopic spine surgery. It's possible to perform a decompression bilateral, as you see. Absolute decompression, over the top decompression. It's a surgery that takes approximately a couple hours, but you can perform really, really complicated multi-levels over the top spinal stenosis decompression with this kind of approaches without any problem. You can also perform cervical disc removal with only a skin incision of 5 millimeters. You can use always the instrument, a shorter and thinner instrument to remove disc herniation on the cervical spine and decompress. Also, you can make a stenosis in the cervical region. Foramen stenosis is also possible to perform with this kind of approaches. I recommend always to start with easy cases, not only with the transforaminal approaches, but also for interaminal approaches. It doesn't matter if you are an experienced surgeon, you should respect the learning curve in endoscopic spine surgery in order to avoid complications. The learning curve will take time, but once you grow up with the technique, you will be able to perform the same surgeries that you do in an open way using an endoscope. Take your time to increase the level of difficulties of the surgery. Start with discectomy L5S1, continue with discectomy L4-5. Afterward, you can perform lateral recess decompression, over the top recompression, spinal stenosis, severe spinal stenosis decompression, and at the end, you will be able to perform cervical and combination with other techniques like cages, implants, and so on. We get in Colombia physicians of all Latin America countries. We have a lab with a integrated navigation system and phantoms and endoscopes to shorten the learning process in endoscopic spine surgery. If you will want to visit us, you are very welcome in Colombia. That was my speech. Thank you very much for your attention.
Okay, thank you so much, Dr. Jose. Still have no question. Maybe I have some questions that maybe how much to this topic is there some fluid irrigation system and endoscopic spine surgery. How much you control the fluid pressure in the lumbar, thorax, and cervical? That is the first question. And second question is that in the cervical area, there also can possibly anterior and posterior approach. What is your indication of posterior approach?
The indication for posterior approaches in spine surgery, in endoscopic spine surgery, are the same indications that you have when you perform an open surgery. The only difference is the way how you perform the surgery. You can do a laminectomy, you can do a foraminotomy, you can perform a discectomy, multi-levels using the endoscopic spine surgery. The only difference is the way of how do you perform that. So I didn't understand really good the first questions. Can you again ask me again the first question, because I was
How much? How
it
you
was a
control
delay.
fluid pressure, maybe some decompression of the cervical and thoracic decompression, sometimes danger with the fluid pressure. How you control the lumbar, thorax, and cervical?
Are you afraid with the neurological deficit? Are you talking about neuromonitoring or something like that?
No. Fluid pressure, irrigation
The
pressure.
fluid pressure, as I told
Yeah.
you before. So I use a system that control automatic the fluid pressure. But when I have this kind of system, I try to use the maximal pressure of the system below the diastolic pressure of the patient. For example, is the diastolic
How
pressure
much? How much?
no
much
more
pressure?
no more than 50.
50. In the
That's
lumbar or thorax, cervical, or?
I always use a endoscope with the oval form in the cannula. So in that case, the pressure that you put inside of the nerve system is not going to be varied by the pressure, because it is always a pressure, a similar pressure of the 15, between 15 and maximal 20 millimeters water. In that case, the problem is when you use a system and when you close the whole system and you put a pressure for a long time. That is a big problem. You can damage the neural structure. So I recommend always to use the system and to try to avoid the cap that many surgeons use in order to increase the pressure inside.
I have one question.
Yeah.
Harrison. Yeah, Dr. Jose, do you teach all your residents the endoscopic spine surgery, or do you prefer to start their learning after finishing normal residency? What is your behavior?
And this is a very good question. Thank you. I think we have to teach the both techniques, because I got the residence in the last learning year. This is normally in the 5th year, and they have been working with open surgery for 4 years. But I think if you have to perform spine endoscopic spine surgery, you have to master the open surgery. I think we have to master both kind of surgeries. But we start with open and then we switch to endoscopic spine.
You know what? At the time of my residency, the chiefs or the senior surgeons were doing microscopic surgery, and they were not allowing the residents to use microscope. Now, probably it is like the similar. They don't allow the current seniors do not allow the residents to use endoscopes. In general saying, And we can discuss it later after finishing all the talks. And I must tell that Dr. Benedikt is with us. He's the other moderator. And thank you for very nice presentation.
Thank you so much.